So Matt, tell us a little bit about your educational background and how you got to be where you are right now doing informatics and infectious disease epidemiology work.
Well, let's see, how far back do we want to go? Yeah, no, basically, no. Again, I just want to give you my disclaimer. It's the end of the day. I got up at 4 o'clock in the morning. I had a grant due today. I'm really tired, so I'm going to be even less articulate than usual.
Okay, no
So,
worries.
So, yeah, so my background is that I went to medical school in Wisconsin, which is in the Midwest. I did my residency in internal medicine at Barnes Hospital, Washington University in St. Louis. And I did an infectious disease fellowship in Boston at Harvard, at Brigham and Women's Hospital and Beth Israel Hospital. And by the end of my fellowship, I had been doing some animal lab work, and I discovered that I was extremely allergic to rodents. And
like physically, not mentally. You were like physically allergic to rodents.
Yes, I would have these incredible sneezing attacks despite wearing masks. I had an N95, and I can tell you this was not pleasant for anybody. And I also had problems with reproducible experiments in the lab, or being able to reproduce my own results. And so I decided that laboratory research was not for me, and chose an academic job at Deaconess Hospital in Boston, you know, in the general area of clinical research. But what happened is that within about a year of starting my first, faculty position, I started to work with an infection that we now call Clostridioides difficile. It used to be called Clostridium difficile infection. And we did a surveillance study where we collected perianal swabs from patients in the hospital to track who was acquiring C. difficile in the hospital. And this was a fairly large-scale study done over almost a year. Involved a laboratory component, but the part that really just where I found my true calling was in working with the data that we were collecting. And the database that I learned how to use was DBase4. And so it was the combination of working with clinical data that we were at that time manually extracting from electronic health records. Deaconess was an early adopter of the electronic health records. Data that we were manually extracting from the records, and this very interesting infectious disease data on, that showed evidence of transmission. This combination of having an epidemiological data set, an important clinical problem, and having, important in different ways to assemble the data, was really my first experience of loving research and really finding my calling in academia. And so what happened over the next few years is that I gained a lot of experience in different kinds of methods, and graduated to better programs than DBase. But more than that, we developed a clinical data warehouse at Deaconess Hospital. And actually, Jonathan, and this is more information than you may have wanted to hear, but Jonathan Nebeker was actually a resident at the time, and Brian knows Jonathan because he's at the University of Utah now. But Jonathan was a resident, and actually I had some encounters with him during our development efforts to create new microbiology data resources, for our single hospital. And this spawned a large number of epidemiological studies, observational studies, where we were looking at the acquisition of other kinds of antibiotic-resistant organisms. And we actually implemented some automated surveillance systems. And this is more than 20 years ago. And I went to my first AMIA in 1997. And because I had an oral presentation at AMIA, I actually missed my chance to use a free ticket to see the Green Bay Packers play the New England Patriots. It was a devastating consequence.
There's decisions we have to make in life. There's opening and closing of doors.
Exactly. But then what happened is I started to get recruited to Utah. And Utah, didn't have the Harvard School of Public Health, but it did have this amazing reputation in informatics. And it was a place where you could, study a problem, but also do something about it. You could, implement decision support. You could do automated surveillance for infection or for adverse drug events. And a lot of this work was pioneered at Intermountain Healthcare. And so the combination of the strength in informatics, the desire to do something that actually made a difference in patient care, and the charisma of the department chair at Utah at the time, Merle Sandy, that is what ultimately persuaded me to come to Utah. And so to make a long story short, my career then evolved in different ways after coming to Utah. One thing I realized around that time was that traditional epidemiological methods were insufficient for dealing with infectious disease problems, because traditional epidemiological methods do not account for transmission. They assume that events in different people are independent. And so for a number of years, I was also seeking to acquire some skills in transmission modeling and mathematical modeling of infectious diseases. And so that was a long effort, and it took a lot of collaboration. I was you could say to some extent a disciple of Mark Lipsitch, who is of course extremely well known now in the COVID era for all of his tremendous contributions for COVID epidemiology. And I also gained experience, developed some agent-based modeling, started to apply these to some problems that we were encountering, not just for healthcare-associated pathogens, but also community pathogens like Streptococcus pneumonia. And so this was kind of the next phase of my work, was to extend the methods to healthcare problems, extend methods from mathematical modeling. And around the same time, I started to work very closely with the CDC. A few years after starting some large CDC grants, I got my first appointment at the VA, at the Veterans Affairs Hospital here in Salt Lake City. And we had a very small center at that time. Our center goes by the acronym, the IDEA Center. And at the time that I joined the VA, again, there was a problem of relative lack of systematic resources for looking at antibiotic resistance across the entire VA system. The VA, as you know, has a homegrown electronic health record based on VISTA CPRS, and these VISTA instances are separate and distinct across all the different VA stations. They have common infrastructure, but very different approaches to coding data. And so there was a tremendous challenge and a need and a void in terms of developing national resources for microbiology and for antibiotic use. So now we're talking maybe 10 to 12 years ago, we embarked on this intensive effort, our center did, to create these resources in microbiology and antibiotic use. And we used natural language processing. And this was a time when the VA made a major investment in NLP to unlock some of the information and knowledge that is embedded in text notes and in VA electronic health records. The VA has had one of the longest standing fully electronic health records for, with fully text notes, fully computerized notes and computer position order entry. And so this was a kind of a next stage where, starting about 10 years ago, we began doing kind of large scale, big data type analyses of VA data across the entire system. 130, 140 hospitals, 1,000 clinics, looking at spread of MRSA, looking at Clostridium difficile, infection now across multiple hospitals, looking at long-term care facilities or nursing homes in VA, looking at outpatient antibiotic use. And then around that time, and now we're talking maybe 5 or 6 years ago, we had developed a critical mass of mathematical modelers who had training in applied math, in advanced biostatistics, use of Bayesian, fitting of Bayesian models. And our team was able to extend existing methods and apply them in an efficient way to the large-scale VA data that we had. And so that work, again, has involved a lot of collaborators all through this whole process. There are numerous collaborators and mentees and colleagues who have played an incredibly important role. And so it was this kind of combination of data science, big data, epidemiological methods, wanting to apply the most advanced methods possible to understand, mechanisms, to understand epidemiological mechanisms and to drive practice improvement and practice change. And so most of our work was focused on the healthcare environment. We had a history of working with other emerging pathogens. We had published on SARS and on Ebola and other emerging infections as they arose, pandemic influenza in 2009. But of course, the COVID epidemic or pandemic is unlike anything else we've experienced. And so, this prior experience is what set us up to be able to offer expertise and experience in using models to understand COVID spread, to help with planning COVID response, and help with designing prospective studies to collect data, to interpret data on COVID prevalence and incidence, and to help support policymaking and decision-making for University of Utah Health System. And across our entire team, we're very involved, not just at a state level, but also with the CDC and also with the VA, locally and nationally. And so COVID has kept me very busy. And I would say that for the last several months, I'm spending the vast proportion of my time on COVID-19 related activities. So that's a quick summary.
So some of what you described about that the VA system didn't have semantic interoperability, et cetera, seems to be kind of a precursor for what's gone on in the U.S. In terms of the public health response. So one of the things I wanted to ask you about, well, first off, have you followed the response outside of the U.S. much in much detail?
Okay, Brian, can you hear me now?
Yeah.
I froze in, so you got to repeat where you I'm sorry.
Okay.
That's the entire question.
So your experience with the VA system where you didn't have semantic interoperability between hospitals when you started,
Exactly.
kind of seems, so one of the things that seems like to me that the COVID experience in the US has highlighted is kind of the disparity between public health infrastructure and medical infrastructure, if that's a fair split. So kind of draw some analogies between your experience with the VA earlier and what's been going on in the collection and dissemination of data with respect to COVID-19. So you pointed me to that. Is it COVID data, the Atlantics project? Yeah. And they grade the different states on data quality. Like they give Utah an A+, but there's B's and C's and D's in there. Yeah. So what have been kind of the real issues in the U.S. that have hampered data collection sharing in the COVID era?
Well, I think that so the the challenge for the U.S. is that everything is federated, and I mean, especially, I mean, but not limited to public health. I mean, obviously education, you know, government in general. And so I think that it, you know, gives the system, if you want to call it a system, it gives it flexibility, and it gives you an ability to do local tailoring, but it complicates the communication and absolutely complicates the interoperability. And so I think that, you know, I mean, a consequence is, and I need you to come back and to repeat the question at least the end part of it, but a consequence of this federation is that every location seems to need to learn the lessons on its own terms. And so we are tending to repeat the same mistakes, just in different locations at different times. But I think that, but the federated system and the you know, the 1,000 points of light that you see in the U.S. is also a remarkable network. And what COVID has brought out is the most engaged point-to-point network of clinicians and epidemiologists and economists and, you know, public health practitioners and you know, business managers and politicians. I mean, the communication networks, which are extremely distributed and decentralized, are very powerful and very effective and very useful. And so I think that, you know, that has mitigated the harm that you get from the challenges of, you know, lack of central coordination. Now, I have to be careful because I'm a federal employee and I'm sitting in a federal facility right now. So I'm not going to, you know, I'm not going to comment. I'm not going to cast stones right now.
Okay.
So, you know, but, you know, if you want to understand the basis for the challenges that the U.S. has faced, I mean, there's a lot of very good material that's been written on that. I can speak from the perspective of someone who consumes a lot of different kinds of data. I have a major focus on the state level, and as you said, we have an A+ rating. You know, so you know, I've found that the access to state data has been excellent. I think that my own experience working with the CDC during this, you know, pandemic has been extremely positive. I mean, the CDC has been very supportive of our work. They, I mean, you know, they're completely accessible to those of us in the field, you know, you know, whether we're in academic medical centers or other kinds of, you know, environments. And they, you know, everyone is problem solving at an intense level. So, yeah.
So, well, kind of to pull it back into informatics a little bit, 2 weeks ago, the New York Times published an article about the fax machine being the bottleneck for the CDC.
Right.
So is reliance on a fax machine to transmit information kind of malpractice?
Yeah, of course it is. I mean, but okay, so I'm glad you reminded me. I was going to make a comment. So, you know, 20 years ago or so, this kind of subdiscipline of informatics was invented, you know, public health informatics. And the CDC had a major commitment to that field or that subdiscipline. And for about 5 years, we had a Center of Excellence in Public Health Informatics funded by the CDC. And one of the great things about that program was that it fostered collaborations with different levels of state government and state and local health agencies, and as well as federal agencies. And so, you know, at that time, the fax was the primary method for communicating results, you know, to the local and state health departments, and in Utah. And you know, I mean, but it was clear at that time, in the far long ago before COVID-19, that that public health was implementation of new public health information technologies is very challenging. I mean, it's probably even more challenging than implementing clinical electronic health records. And many solutions were tried and abandoned, and then tried again. And I think there's probably a learning process associated with that. I think one of the challenges working in public health or government in general is that that there's it can be difficult to the public scrutiny can sometimes create pressures that also create challenges. And so in any case, I would say that the issues of electronic laboratory reporting, of having a consistent approach to reporting across all the states, to the CDC, all that was were the top priorities for the efforts that we worked on 10 or 15 years ago with CDC and local and state health departments. So these are problems that are just hard problems to solve, I think.
Is it also as and this is kind of a not so much a political question as kind of a cultural values, has public health been underinvested in relative?
Oh, yeah,
I mean, so I remember when we were at San Diego, Don Lindbergh visited and said America went wrong when it viewed public health as medicine for poor people.
Right. And I mean, one of the things that always fascinated me was that most people in clinical practice don't understand the concept of public health practice. There's some misconceptions about what public health entails, and lack of appreciation. I mean, it's the classic thing of if there is no problem, then the benefit and the effect of the public health agency is not appreciated. Right. It's not visible.
Right. So do you have any insights on kind of differences in practice from maybe kind of informatics perspective of the states like Utah that have an A+ on their data rating and states that aren't doing as well?
Yeah, no, that's a great question. I mean, I can't say that I do have particular insights about other states. I think that probably there's a correlation between effective public health practice in other areas and in other ways, like investigation and response, a correlation between effectiveness in those domains and effectiveness in surveillance and reporting. So it's probably hard to do one effectively without the other. And I think it also just, the quality of the program has effects across the board. Again, not just on the informatics side, but just on the public health practice side. But I mean, we just don't. I don't have a window into what's happening in other states, except that on various CDC calls where we interact with other academic medical centers who are participating in various programs, like what's called the Prevention Epicenter program. We do hear about some of the chaos that went on early in the pandemic around testing. One of the benefits that we had here in Utah specifically was having ARDP, a major reference lab associated with the University of Utah, as a resource. So that was an asset that the public health agencies here took advantage of appropriately. Yeah, I mean, I think that we're a complex adaptive system. I mean, and public health as a complex adaptive system deserves study, and those kinds of studies are the study of public health error, for example, was something that interested us again back when we had a Center of Excellence in Public Health Informatics. I mean, I think they tend to be just relatively understudied in the public health setting because research is not really baked into public health like it is in clinical medicine.
Okay. Kind of talking about complex adaptive systems, and you have these arbitrary state lines, and I think Australia is experiencing similar kind of questions in terms of there's some things that the federal government's responsible for, some things that the state governments are for, and it creates strange dynamics. But also you have these arbitrary political boundaries that don't necessarily match geographic
Right.
or economic boundaries. And so like Victoria borders closed with New South Wales, but there's a lot of flow. There's a lot of catchment where the Utah hospitals are treating Idaho, Nevada, Wyoming would probably be obvious ones, citizens. So are there kind of adaptive kind of meta-state public health relationships?
Yeah, no, there are personal affiliations. I mean, these networks are based on a lot of affiliations, many of which were pre-existing, but some of which have developed in the COVID era, during the COVID era. Yeah, I mean, I think that, yeah, I mean, the challenge is that it's just, we never quite have enough data. I mean, all the data about, how much behavior had changed, during the period when much of the U.S. shut down. The data about social distancing behaviors and mask use and who was continuing to work and what what work practices were or and are. I think all that. I mean, there's there's absolutely a need to enhance our ability to respond nimbly to small outbreaks at an early phase. And the state of Utah and many other states have done a lot to expand their contact tracing personnel, but this is such a massive undertaking. I mean, it's not surprising that it's been challenging to keep up with a disease that's causing hundreds or thousands of cases a day,
Yeah.
in a given state.
Well, I think COVID, I've been following a little bit about the tracing apps. It doesn't seem like any of them have worked out very well, that any of the governments, well, maybe, China, but
or South Korea.
Most tracing apps have failed, right? With
yeah.
Yeah.
I mean, as far as I can tell, it has not been adopted widely in Utah. The contact tracing component of the app that was developed here.
Well, I think in Australia they have this COVID safe that was really pushed hard by the government. You never hear about it anymore. And
yeah, but I will say that so I'm very deeply involved in this HERO project, which is a community prevalence study or project where we test antibody and PCR of randomly a random sample of the population across multiple counties. And our next phase of that project, by the way, is addressing school transmission. But one thing that we found, because we contacted individuals who were found to be PCR positive, based on our testing, is that they were reached by health departments.
So Matt, maybe tell us what PCR is.
Oh, polymerase chain reaction. So it's the major, the primary diagnostic test to determine whether someone is infectious or has COVID-19 infection, as opposed to the antibody test, which detects previous infection. The antibody response takes at least 7 to 14 days to be mounted, and so it doesn't tell you who's currently infectious. It tells you something about the cumulative number of infections in your region. And although the problem with the antibody test that we're learning is that the amount of antibody tends to fade with time.
Okay.
So anyhow, yeah, I mean, what I was going to say is that, so we found that fully about a third of our individuals who were seropositive, who had antibody, had a history of a positive PCR tests in the past. So Utah has a very good ratio of seroprevalence to case counts. And what I also found in contacting participants in the project who were PCR positive, we were contacting them to let them know that they needed to be isolated, that that they would be contacted by the health department for the purpose of contact investigation. And what I found is that the health departments were reaching out to these people, and in many cases, people that were testing positive had known they had a previous positive test. So, it was kind of an independent check, if you will, of whether we're actually keeping up with the needs of contact tracing a lot, hundreds of people a day, and that responsibility falls predominantly on the local health departments. So that's again part of the distribution of tasks and responsibilities across the different levels of health, public health.
Yep. Robob, I wanted to give you the opportunity to ask some questions.
Oh, thank you, Brian. Actually, I prefer just to be a listener and learn from Matthew's valuable experience as much as I could. So please, you go ahead. It's just so excellent stories, actually. Yeah, thank you, Matthew.
Thank you.
What would you? So one thing that you kind of mentioned earlier that I wanted to just get your thoughts on a little bit. That's a little bit of a change of pace. Is your early, well, you're getting started in mathematical modeling, because
Yeah.
I think of different ways that we can represent knowledge. I think of like ontologies as a formal expression of knowledge, probabilities as an expression of knowledge, but I also think of mathematical equations as
Totally.
another way of expressing medical knowledge, but doesn't seem to be maybe I don't know, orthodox doesn't seem like the right view, but a mainstream view of ways that we should be thinking about that we can share knowledge. What are your thoughts about mathematics as an expression of medical knowledge?
Oh, it's very powerful. I mean, what's great is that the spectrum of tools that you can use, from very simple compartmental models that just are very broad abstractions of reality, but still have this core truth and give you these deep insights about the behavior of infectious disease is such a rich domain to use mathematical models, because it's so interesting because infectious diseases are nonlinear problems, and yeah, I mean, but then so you have these simple compartmental models that give you fundamental truths and insights, and then you have agent-based models at the other side that that can much more closely represent reality. And when you're creating agent-based models, you feel the sense of being God. It's something that allows you to pour your knowledge into it, because you can represent all the deep details at the individual, at the different levels of different kinds of individual agents. And but I think, the thing that I've been just, one of the things I'm most interested in is, again, but how do you convey those results? How do you convey the utility? I mean, I discovered early on that just showing people equations or complicated visualizations of agent-based models was not very effective. And so I think there's so much work that needs to be done on user-centered design for representing the outputs of mathematical models and simulations, and to make them interactive. And I remember a lot of discussions with Charlene Weir, one of our professors in biomedical informatics, who, was, is also a psychologist, who, talked about, the benefit of giving people tools that they can play with, the benefit of exploration. And so that's something that we've sought to develop, but it's a challenge, because especially when you're using statistical models to estimate parameters from data, you're fitting dynamic statistical models, Bayesian models, for example, to infection data. Those kinds of algorithms are very difficult to explain, and so and difficult to implement. So I would say, again, it's kind of a lifetime goal for me to infuse epidemiology with mechanistic thinking, mathematical models, and also then to turn it into population health decision support, which is just a different problem, because we're not necessarily giving people instructions of if then if we're not giving simple algorithms of or protocols to decide on an intervention or a policy. Rather we're providing information that is digested and kind of assimilated along with a lot of other data, with other with other elements of the decision-making process. So I think, again, to me, that's a challenge that really brings together the epidemiology and the informatics, thinking about the decision support for public health.
Okay, I'm gonna wrap up with two questions.
Okay.
One is, what would be like the #1 takeaway from informatics that you would want every clinician to know? And the second is, what would you want every, because this class that, that I'm creating this video for is for computing and information systems people, most of whom have no clinical experience. What would you want that group of people to be their main informatics takeaway? So I can remind you of that one after you answer the clinical, like medical students or nursing students.
But I thought you were asking the complement. So what informatics principles or ideas are critical for clinicians to know, and vice versa, what medical and clinical...
Oh, yeah, that's fine. Yeah, yeah. Let's answer that.
Well, because I feel like I live on both worlds. I mean, it's kind of, it's another story of my career, is working at the interface of different disciplines. So I think that, I think maybe the two biggest things are the idea that informatics is not just information technology, that it's information, and so that's a much broader view of that opens up all kinds of doors around decision making, and it opens up doors in terms of the spectrum of tools that can be used to support clinical practice. And I think that the other, the other thing that I think, the other principle that I really like, that Chuck Friedman, I think, was the first person to.
Randy Miller says he is, but.
Wait, say that again.
I think Randy Miller claims he is, but Chuck certainly wanted to popularize it. Sorry to interject.
Right. What is the fundamental theorem of informatics? That it's human plus computers are better than humans alone at decision making and processing information. So the idea that that there's that the role of the human decision maker is always going to be very important, and we're trying to enhance that decision making capacity, adding to it the artificial intelligence, the data assembly, the data interpretation, etc., that we get from from informatics tools. So okay, those are the things that I think the clinicians should know. what should the informaticists or informaticians or computer scientists know? I think that, okay, and let me stop for a second and ponder that a little bit. But I mean, I would say that I would say, you know, probably the first task that you have is to learn the new language. You know, I think that probably is just, you know, maybe the biggest initial barrier that computer scientists and non-clinician informaticians have, you know, to understanding and you know, understanding what's happening in healthcare, and also the barrier to speaking with clinicians and working with clinicians. And I think that, yeah, I mean, I guess, I mean, the other comment I have, you know, that, you know, is generally true, but, you know, I think is a useful lesson that informaticians can apply, is that, you know, a lot of the most important advances in medicine, you know, have come from, you know, disciplines outside of medicine, you know, where or from domains outside of medicine. You know, so I'm thinking of all the advances in patient safety, you know, where, you know, so much progress was made in transposing lessons learned and theories and models from other industries like the airline industry and applying them in the healthcare context. So I think that, I think informaticians and computer scientists who have this experience outside of healthcare do have you know, a lot to contribute in healthcare and can adapt that experience into the healthcare environment. Having said that, I will comment that in the COVID era, everybody is an epidemiologist. So I find that to be very interesting and sometimes a little bit challenging. However, what I've learned is that now that we're, you know, several months into the COVID pandemic, I do find that a lot of the people that I work with who are coming at this problem from outside of healthcare do have great ideas and contributions to make. So maybe it is true that everyone can't be an epidemiologist in the time of pandemic.
Well, thanks, Matt. Robob, any thing you want to wrap up?
Yeah, it was really interesting talk, and thanks, Matthew, for that. But I just have a question about the latest comment that you added in there, which is really, you know, confusing to me. That to what extent the, you know, people coming from IT background have to learn the, you know, the clinical knowledge, because, you know, it's quite broad, and for clinicians takes several years, you know, to learn the basics, the terminologies, you know, and everything. Or we can have those health informaticians in the middle between the IT
Right.
and the clinician.
Right. No, but it's, I think it's the language. I mean, it's not necessarily the knowledge. I mean, I think it's hard to have the knowledge without the language. So I think the language is a prerequisite to having knowledge, but it's not developing expert clinical knowledge, but it's being facile in communication. And I think it's, you know, it's like studying a foreign language, you know, learning a second language or a third language. It opens up, you know, a dimension of experience and understanding of a different culture or a different country that would otherwise be unavailable or inaccessible. So I think, yeah, so I think that, you know, a lot of what is, you know, it's true that the language kind of encodes the expertise, you know, that clinicians have, but you know, gaining some familiarity and an ability to listen to the discussion about a clinical topic and understand what the words mean, and have, you know, sufficient graphs to you know, to track, you know, the content without having to have expert knowledge. I think the language, getting familiarity with the language would go a tremendous way.
And that kind of reminds me of Fred Adler's adage that I use a lot about every mathematical equation tells a story, and then there's also technical details about that equation. And so in some sense, the non-mathematician, we want them to understand the story,
right,
and we leave the technical details to the mathematician. That sounds very similar to what you're saying with medicine.
Yes, and
really
Fred is, you know, he has very profound insights. Very, very, very wise man.
All right, well, thanks, Matt. I'll let you get off to your weekend. Do you have a happy hour coming up, or you just, or that's COVID out?
Only virtual happy hour.
So, all right, well, thanks, Matt.
Yeah,
okay,
thank
nice
you
to talk with you.
Matt, for giving us your valuable time, and I'm sure it's going to be quite interesting to all students to listen.
Thank you so much. Thank you. Bye-bye now.